I like the sort of the mix of medicine and surgery, and in Australia we're probably one of the clinical leaders. We're obviously treating more patients purely because of the workflow, the advantageous workflow of the Gamma Knife.
Dr Neda Haghighi leads the Gamma Knife service and neuro-oncology unit at Peter MacCallum Cancer Center in Australia. As a senior radiation oncologist, she played a key role in bringing Leksell Gamma Knife technology to Peter Mac in 2020, transforming their approach to cranial radiosurgery and shifting up to 80% of brain cases from linac-based SRS to Gamma Knife radiosurgery. Under her leadership, the program has expanded to treat a broad range of malignant, benign, vascular and functional conditions. In this episode, we explore how Gamma Knife has changed clinical practice at Peter Mac and hear highlights from Neda's impactful career.
Welcome to this episode of Spilling the RT. I'm your host, Emily Bassett. So my name is Neda Haghighi. I'm a radiation oncologist. I work at the Peter MacCallum Cancer Center in Melbourne, Victoria, Australia, and also at I Cancer Center. At Peter MacCallum, I lead the neuro-oncology unit, and I'm the clinical lead for the Gamma Knife service in Victoria.
So what would you say first drew you to radiation oncology and then eventually the practice of stereotactic radiosurgery?
So, yeah, I left medical school and had a goal to become a neurosurgeon. So that was my goal in life. So I spent a couple of years doing surgical training and did in fact do some work as a junior doctor in a neurosurgery department. I, by chance, ended up doing a short rotation in a radiation oncology department in Melbourne at Peter MacCallum. And it was almost like the light bulb sort of just turned on. And I really enjoyed it. I liked the sort of the mix of medicine and surgery and imaging. And I had a very good mentor on that rotation who convinced me that this was what I should do. And that's where I went. And then I found my way back to neuro-oncology or to neurosurgery in a way, in that I now do something similar to neurosurgery without it being invasive. So
that's amazing. And yes, you mentioned mentors, and sort of I was going to ask you sort of how important you feel like mentors have been in your career journey, because you're now getting more involved in things like mentoring in your career of others.
yeah, no, absolutely. I think mentors play a key role in what you sort of end up doing in life, but also they can make such an important impression on you that they can change your path, but also the way you think about patients in the clinic. So I've had probably a couple of really strong mentors in my path. Certainly in radiation oncology, there've been a few people who've helped me along. And to get into neuro-oncology, I knew always I was interested in neuro-oncology, and I ended up doing a fellowship, over about an 18-month fellowship, with one of the radiation oncologists in Melbourne who really introduced radiosurgery to Melbourne 3 or 4 decades ago. So I was lucky that he took me under his wing, and that's how I started.
Because you're now a member of sort of multiple stereotactic groups and chair of, I'm probably going to say this wrong, is it SIGA?
Yes, correct. Yeah.
So
Yeah.
do you think that's kind of influenced you taking a bit more of a sort of leadership role in that
Absolutely.
space?
Yeah, absolutely. And when SIGA started, so Melbourne, even I'd say 5-10 years ago, there was really only maybe 2 centres that were offering radiosurgery and had the expertise. And then SIGA sort of came together in 2018 by 3 of my colleagues. So people like-minded like myself from Melbourne, Sydney and Queensland. And they asked me to join. And it was an excellent opportunity to actually be able to educate our peers, because we could see the growth of the discipline and the interest. And there was a huge interest amongst our colleagues. People wanted to learn about radiosurgery, they wanted to understand. And back then, the debate around hormone radiotherapy and radiosurgery was still quite live and vivid, and people were interested. And for myself, particularly, learned a lot of my radiosurgery from going to ISRS. So, while some of these mentors don't know me, but some of the, just going to ISRS, I learned a lot about benign disease and management of benign disease by listening to the pioneers. People like Jason Sheehan and Bruce Pollock, and I can name a few of them that really influenced me and the way I was thinking about radiosurgery and what you could use it for. So I could, as I was progressing in my career and I was doing more and more of it and learning along the way, obviously the opportunity to be able to teach others, and this was happening in parallel with multiple centers in Melbourne introducing radiosurgery techniques. So getting linac accelerators that had the capability of delivering stereotactic radiotherapy. So there was a need for this, and SIGA has been fantastic. I mean, so we have used it as a platform. It's now quite a big annual meeting where we have international speakers and everyone interested to come, and it's really grown, and it's lovely to be able to teach. Yeah.
I think having that sort of sense of consortium is really important when you're establishing kind of newer techniques. And you mentioned a sort of a nod to the landscape a little bit. So you're actually the first radiation oncologist who's been based in Australia that we've had on the podcast.
Oh, really?
Yeah, I don't know why it's taken me 8 episodes. Shame on me.
That's lovely. Thank you.
Yeah, no, really, really delighted to have you on. Could you just say a little bit about kind of the landscape of radiation oncology in Australia? For someone who might be listening who doesn't know, in the context of both opportunities and maybe challenges.
Oh, look, I think Australia is really in radiation oncology, particularly. I think we're one of the pioneering countries. We're very lucky that we got large sort of academic support and research platforms with trial groups and people who are happy to support us and be able to run clinical trials. And with introduction of stereotactic radiosurgery for brain tumors, but also for body radiotherapy. We really, particularly at Peter MacCallum, the SBRT or the SABR unit have really expanded and become one of the world leaders really in what they've been able to produce. Obviously, I'm not a part of it, but it's just been amazing to watch. There's a huge appetite, and even within all the different disciplines of radiation oncology, so not just stereotactic management. We have been lucky that the government have been, each state government have been happy to put money in allowing us to have equipment like MR linacs and Gamma Knife machines now, and to be able to advance not only in our research but also in what we've been able to provide in terms of clinical care. So I think as in Australia, we're probably one of the clinical leaders, and you can sort of see that reflected in the again, as part of my position at Peter MacCallum, I oversee the fellows. So we have a very big fellowship program. And as well as we get a lot of observers from overseas and other hospitals coming in, and the demand for international sort of guests to come has really come up. So a lot of internationals are now wanting to come to Australia to do fellowships, to do observerships, to do sabbaticals. So we're seeing more and more of that. So so certainly I think we've really progressed. The shortcomings, I think. I don't actually know. But look, it's hard. I can only see the positives. I mean, the other thing that I was recently, I know a little bit about how the European system works, and I know most of the European countries are heavily based on a public service, so public hospitals and public service, which has been wonderful. And I grew up a European country, and to be able to have access to all that.
So would you mind explaining how the implementation of Gamma Knife in 2020, which I know you were very much a big part of, has impacted the treatment approach there for patients with different brain conditions?
Yeah, so we had again, because we did have a sort of, we were treating patients with stereotactic radiotherapy long before we got the Gamma Knife. So we had the clinical knowledge in Melbourne when it arrived at the VCCC or the Peter MacCallum. But what we didn't know was how much more we could do than we were able to previously. So, so two main things that happened. We're obviously treating more patients. So, we're treating many more patients with brain metastases purely because of the workflow, the advantageous workflow of the Gamma Knife. We can get the patients through much quicker. The patient have hardly any downtime, any recovery. And we do offer, this treatment it's a statewide service. So the people coming from 2-3 hours away, and the fact that they can come now and have everything done in one day, as opposed to before, it would take us 2 weeks before the treatment was over and done with. That's a huge change. With the implementation of the Gamma Knife, we've also upskilled a lot of our colleagues who were not on the neuro-oncology unit before. So they would have been on the lung unit or a melanoma unit, but they had an interest. So we've upskilled them now, so they can also now treat brain metastases, and that's just allowed more people to be treated. They used to previously often be offered whole brain radiation, but now because people are skilled and they see the ease of the use of the Gamma Knife and how efficient it is, so more people are being treated. Again, the other advantage is that with clinical trials, we've been able to, that being an extremely academic center, Peter MacCallum, we run several clinical trials for most tumor streams, and often these patients would have had to have the brain disease under control before they could get on the trial. Again, we can do that very quickly. We have trials now where I can tell you, I'm the site PR for one of the melanoma brain metastasis trial called ABCX, where we have to give the radiosurgery on the same day as they start the immunotherapy. And with the Gamma Knife, we can only do it on the Gamma Knife because the timing is so critical. So within days, we need to plan it all. It can only happen with Gamma Knife. So that's been a tremendous change. For me personally, I have an interest in skull-based disease and benign brain tumors, vascular disease, and it's been a tremendous tool for me. I mean, I was treating them before, but often over several weeks or
that was linac-based radiosurgery.
Yeah, on the linac-based radiosurgery, and I still use the linac accelerator for fractional radiotherapy treatments for large skull-based tumors, but it has having it there. It because of a number of things, including occasionally also dosimetric advantages with regards to what I can achieve to organs at risk. I have, it's just allowed me to treat more patients, and we've been able to offer the service to more patients. I was using the linac accelerator maybe once a year or once every 2 years to treat AVMs, and now we're treating 1 or 2 a month. So it's been really good for us. And the other thing that it's done is that we in Australia in general, it's taken the neurosurgeons a long time to get used to the idea of radiosurgery. It's quite divided in Australia. So radiosurgery is only delivered by a radiation oncologist, and neurosurgeons do surgery. So and there was for a long time a big hesitance about referring to radiosurgery, but I think the Gamma Knife has they've seen the results now, and they can see the availability, and they understand it. I think they understand Gamma Knife radiosurgery better than stereotactic radiotherapy because it was radiation. Whereas they don't, there's a bit of, they've come around, they can see the advantages, and they're interested in. I mean, I'm really grateful to have colleagues that I really look up to who are actually interested and want to be involved and actually understand, to get their advice about, often, particularly with benign disease, you want to, you need to sort of work in a team. You can't, you have your basics, the radiology, and you have your patient, you have an interpretation of the disease, your knowledge of natural history and things, but having a surgeon on board who understands the anatomical aspects or has been in there with a microscope often makes a huge difference to get that. And I feel like that's really only come around with a Gamma Knife, that I now have got that interest from the neurosurgeons. So there's been, so that's been some of the reasons why we are treating more patients because of those factors. Pain, trigeminal, we treat a lot of trigeminal neuralgia, so that's one of my interest areas. But Yeah, so and there's still room for growth. There's a lot. I mean, Melbourne's a big city.
Yeah.
You know, we Melbourne's getting another Gamma Knife in the next 6 months, and we can certainly service the city. I mean, we could have three, and we could still. There's plenty of patients we could treat. So
You mentioned the AVMs and trigeminal neuralgias. Do you mind, just in case there's someone listening who doesn't know what they are, just sort of explaining what they are? Because you mentioned pain and yeah.
yeah, so AVMs are just deformed nest of vessels in the brain where the arteries bypass the right path to the veins, and they create this nest of fragile vessels that have this propensity to bleed and can be lethal if they bleed. And they are often cured with surgery, so surgery is really preferred if it's possible. However, there's some of them that can't have surgery because they're too deep-seated or they're too large, or and that's when radiosurgery comes in. So gamma knife radiosurgery can be quite effective. It depends on a number of things, but it can be quite effective and a very good alternative treatment option. Often these patients are young, so it's nice to be able to have an option for them when the surgeon said we can't treat you, and they have something in the head that might bleed. So yeah.
Yeah, that's quite a scary prospect to be faced with. And
Yeah.
then trigeminal
So
neuralgia.
trigeminal neuralgia, it's a pain syndrome where people can get extreme pain on their face. And it can be sort of clusters of electric type shock or pain that is quite debilitating and can basically annihilate a person's quality of life if it's severe enough. Um, so there's sporadic, there's no reason for people having it. There's a few conditions that can cause it, and then sometimes there's an anatomical problem where the vessel's riding on a nerve and can cause it. We think that's the reason. Again, surgery is a great option. So there's a few sort of invasive procedures they can go through. MVD, which is microvascular decompression, is a big operation. So often, again, these patients, the cohort of patients are often older patients. So often they can't have surgery because it's a big operation and they go on medication, they can't tolerate the medication. And then gamma knife radiosurgery is a nice, non-invasive, fairly quick treatment with reasonably good response rates for pain. It's actually one of the nicest things to treat as a radiation oncologist, because it's really rewarding. So you often treat benign brain tumors and things, they stop from growing. You don't really see them shrink or go away, but pain's always nice because they come and give you a hug, and patients get very grateful. Yeah.
Something like that, I think, is so anything in your head is so
Yeah.
intense as well. Like even if you have a toothache, it's so
Yeah. It's
distracting and
painful. And to get it several times a day, they can't eat, they can't, it's horrible.
Gamma knife radiosurgery, a revolutionary non-invasive technology for treating brain tumours and benign conditions. Despite its name, the Gamma Knife isn't a knife at all, but a precise medical device that uses focused beams of gamma radiation to treat brain tumours or disorders without surgery. Gamma knife radiosurgery delivers hundreds of tiny beams of radiation, all converging on a specific point. This allows clinicians to treat lesions or tumours ranging from just a millimetre to several centimetres, and even the most challenging lesions with pinpoint accuracy, while sparing healthy tissue. Gamma knife treatment is often recommended when tumours or lesions are located near critical brain areas, or when traditional surgery poses too much risk. It's also ideal for patients who are too unwell for surgery or who have already undergone other treatments. Leksell Gamma Knife is clinically proven to treat a range of conditions, including malignant brain tumours such as glioblastoma and brain metastases, benign tumours such as acoustic neuromas, so tumours affecting hearing and balance, meningiomas, slow-growing tumours arising from the membranes covering the brain, and pituitary adenomas, non-cancerous growths in the pituitary gland. It's also clinically proven to treat arteriovenous malformations, or AVM, abnormal tangles of blood vessels, trigeminal neuralgia, a chronic facial pain caused by nerve dysfunction, essential tremor, uncontrollable shaking, often of the hands, and epilepsy, neurological condition causing unprovoked recurrent seizures. Gamma knife radiosurgery offers high rates of tumour control and symptom relief, with minimal side effects and no incisions. Over time, treated lesions shrink or stop growing, and patients experience improved quality of life. It does feel like a bit of a full circle moment for you, saying you wanted to be a neurosurgeon and then you sort of graduated to all of these benign conditions.
I think I conned my way into it somehow without actually having to. No, I'm nowhere near. I mean, I'm very interested. Obviously, brains and neuro-oncology is something I've been fascinated about. So yeah.
So you, I think I was going to say that from Astro, or way before that this year, and we've talked about benign on the podcast a bit. It feels like benign conditions are having a bit of a moment with radiation, and people are getting more interested in conditions. And I think there's sometimes this feeling that like benign is fine, but as benign tumors and conditions can have such a huge impact on quality of life. How would you say that Gamma Knife in particular offers a benefit for these sort of patients? So maybe ones that have pituitary adenomas and angiomas as well.
Yeah. So again, people with benign tumors have got a full life ahead of them. So we don't usually see their life expectancy shortened if we can cure these tumors. And so when we give them treatment, we have to be very mindful about late effects and any morbidity or any toxicity. And again, that's why I think the Gamma Knife is possibly, or stereotactic radiosurgery, superior, because it does allow us to minimize radiation dose to important structures in the brain. So someone with a schwannoma in the ear, where we want to minimize the dose to the hearing apparatus to preserve hearing, and possibly can get a better outcome on the Gamma Knife just because the dose is just lower. Whereas or someone with a pituitary adenoma, where you want to avoid the optic nerve, and you could fraction it, you could put them on the linac accelerator, and you could give the radiation over 28 days and make them come in and out. And we don't really, then, you can quote them low chance of risk, but logistically, in terms of life quality, life effects, it's very different to just one treatment on the Gamma Knife. So I think overall, we can minimize risk because we give lower doses to adjacent structures, and that's the beauty. Most of the benign tumors, the risk of late morbidity, even in the long-term data, it would be less than 5% or less than 6% of nerve damage. All those things are very low risk. So that's why it's advantageous.
Do you have a particular moment when you felt particularly grateful for having access to a Gamma Knife? Is there anything that stands out?
Oh yeah. I mean, I think all of us who have access to it and use it on a daily basis, we feel very grateful that we have. I mean, again, I feel very, very spoiled to do this job and work in a place where I have access to all these different tools. I have a, linac accelerator that's spec'd up to be able to deliver stereotactic radiotherapy, and I've got a Gamma Knife when that's appropriate. So I'm at a particular moment. I think it was a milestone. First time I treated when I treated the first patient, I still remember it was a lady with a cavernous sinus meningioma. That was a big moment, and it was a big moment when we treated 1,000 patients. It's always a big moment where I think where you can go and talk to the patient about what you've been able to us every time obviously the patients go through the process. Once we finished the radiation planning, I always go out and have a discussion with them and explain to them what we've done. And that's quite special to be able to explain to the patients and why we do it and how low the dose is and what I would expect them to be able to. So I think every day is a good day on the Gamma Knife.
Yeah. Can I ask as well, because I believe about 90%, you've sort of shifted 90% of your brain cases from linac-based SRS to Gamma
Pretty
Knife.
much, yeah, yeah,
So
yeah.
does that mean that you've sort of freed up your linacs for more patients, or you just finding you're now getting more referrals and a bigger volume of
No.
brain? Okay.
Yeah,
Yeah.
no, well, it's both. So it's both. So we're getting more referrals. So the linacs, so I'll probably say probably 80%. So we
Mm.
treat all our surgical cavities on on the linac.
Yeah.
I don't feel comfortable with the symmetry of the Gamma Knife and when you use margins. So we put them on the linac. And then we for myself, larger skull-based things, I still use the linac. What it allowed us though, because we also on the same linac that we do SRS for brain and for CNS conditions, the same linac is used for SABR or SBRT. So
Yeah. Okay.
and as I explained, our SABR unit has gone global, exponential, and we were often competing with the Sabre unit against time on the linac. So what it allows us to do is just create more space for Sabre patients and body patients to be treated. Which is wonderful. So and then, as you said, we've now also got more referrals. So they're both quite full. So yeah.
That's great. I was just curious because I sort of read that stat in a Focus article actually that you were interviewed for as well. So thank you. You mentioned before getting a hug from a patient. How do patients generally respond to having treatment on the Galba knife, would you say, in terms of their sort
Yeah.
of experience?
Look, I think it's pretty smooth for most patients. It's rare, we use so about at least I think about 60 or 70% of our patients are still mass-based treatments. So might even be higher. I haven't had a look at the stats this year yet. At the end of this year, I'll have to have a look at it again. So a lot of patients are done in a mask, and it's pretty straightforward for them. And most people tolerate it quite well. And it's very rare to have any major acute complications. The recovery very quick. We tend to have this service where all patients are called within a week by our Gamma Knife nurse, and then we talk to them as well. And it's extremely rare to hear anyone not recovering soon after. Um, so that is going quite well, and with our frame based treatments as well. I think because we hadn't used frames, although I did when I was a training doctor at the hospital I was training at. We were back then doing frames, but um, we were worried about the frames, and we were worried about the rigid immobilization recovery, but it actually hasn't been a big problem at all. Most patients recover very quickly. The feedback has always been quite good. It's never about, so often when I see patients following treatment, it's not really so much about the treatment. They're very grateful. They're very grateful for the staff. It's always a conversation about what does the scan show after treatment. So it's all about
Mm.
following up. People are not too worried about what happened on the day.
I've noticed a lot of sort of patient content I see online is based, if they have frame-based radiosurgery as well, they like to share
Yeah.
the video and the photos of them with the
Yeah,
frame
yeah,
on
yeah,
their head. That seems to be the focus of the
yeah,
actual
yeah,
treatment. So yeah.
yeah.
So so I was going to ask if you felt a bit nervous about switching to masks, but it seems like that was more
No, so we were so comfortable with mask already because all our linac-based radio, we were, that was not a problem at all. We knew what to do there.
yeah.
Our radiation therapist picked it up straight away, and there was not an issue with that as well. There was a steep learning curve for our rigid immobilization, but I work with so our neurosurgeon, who's our Gamma Knife neurosurgeon, he had done the course in Pittsburgh, and it wasn't a problem at all. And very quickly, we worked out that process and the workflow. And we now got 2 neurosurgeons I work with who help us with the frames. And it hasn't been. And generally, the recovery, people worry, people from other hospitals who don't use the Gamma Knife tell patients so scary stories about, oh, they're going to screw something in your head. But it's really, some patients prefer it actually because they don't. I promise you. I mean, again, this was Thursday last week, and a lady who I could have done in a mask insisted on the frame because she felt claustrophobic about the mask. So yeah.
I didn't think about claustrophobia. I was thinking maybe it feels more secure, obviously, because there's sort of
Yeah, it
like
doesn't move. Yeah, it just
bolts
gives
and
you the
braces
extra.
and yeah,
Yeah, yeah.
yeah. Oh, that's interesting. And can I ask you if you mentioned a couple of trials at the beginning? Are you looking at systemic therapies at all, Peter Mac, in combination with Gamma
Oh,
Knife?
oh yes, there's plenty. I mean, yes, in combination with Gamma Knife. I mean, I mentioned ABCX trial. I'm just a site PI. I am. It's run by the medical oncology team, the Melanoma Institute in Sydney, and Professor Georgina Long, and we run the trial at Peter Mac, and yes, so that's one of them that I'm involved in. I know of. We don't have any other sort of concurrent systemic therapy. We had another trial run by TROG, which is closed now, which was EGFR mutated lung cancer and radiosurgery and TKRs. That's not the outrun trial. It's now closed. Currently, there's no other ones that I'm aware of at Peter MacCallum.
Hmm. Can you tell us a bit more about the trial that you're involved in at the moment?
Yeah, so I've been I got interested in the use of radiosurgery in a preoperative setting for brain metastases about 6 years ago now, maybe even longer. I think 2018 was the first patient I treated. There was a surgeon in Melbourne who raised this with me as an option instead of giving radiosurgery to the cavity in the postoperative setting. We'd had a few patients who developed leptomeningeal disease after cavity radiosurgery. And around that same time, there was data coming out of the US around sort of this concept of preoperative radiosurgery, which was very controversial. And we started doing it, and I eventually sort of created a database, and we published on it, and I got involved with international colleagues, and we've been able to sort of achieve a few publications, and it will most likely become standard of care in the next few years. There's a lot of larger radiosurgery centers that are using radiosurgery in the preoperative setting now instead of postoperatively due to the cavity. It's got a number of advantages, and I'm not going to go into that in detail. I looking at my own results, looking at the international results, I started seeing a difference in patients having had one dose of radiosurgery, which is often dose reduced, as opposed to 3 doses of radiosurgery, which is something we can do now with the Gamma Knife. With the mask, we can fractionate them. And we in Melbourne always were quite comfortable with fractionation. In general, Australia, because we are linac based prior to the Gamma Knife, we're very, very happy to fractionate. So I could see a different, there was a sort of a signal in just could see people did better, as in the tumor control was higher when you were using fractionation. So I proposed to the Tasman radiation oncology groups, trial groups, this concept of this trial a couple of years ago in 2023, which was really looking at comparing single fraction versus multiple fraction radiosurgery preoperatively. And then I got a lot of momentum and a lot of interest, and from there on, we now have a trial that is, so we just had the ethics approved, and we've got enough money to get it started. We just got another small grant and through one of the partnerships, so we should get it started and opened in Australia at 3 centres. So one in Brisbane, one in Melbourne, and one in Adelaide, and early next year. And hopefully with more money, we can open it more and compare these 2 settings. And that will help really build the evidence around this new, not technology, I suppose, novel way of thinking about radiosurgery for brain metastases that need resection. Because the evidence, there's randomized trials now that will be published in the next 12 to 18 months, likely showing superiority with single fraction, most likely. So this will hopefully add to the evidence and help us inform the patients better about treatment.
It sounds great. And does it have a name yet? Have you not named it yet?
Yeah, it does have a name. It's called the SMART trial, SMART.
It's a good name.
Not very inventive.
Oh, well, I wish you all the best with that across
Thank you so
the 3
much. Thank
centres. And
you.
yeah, like you say, hopefully it just adds to that growing body. And yeah, amazing. Thank
Excellent.
you. Thanks for
Beautiful.
sharing that.
Thank you. My pleasure. Thank you for having me on.
If you enjoyed today's episode, then don't forget to like and subscribe wherever it is on your screen, and tune in for the next episode.